Hello and welcome to everyone. I'm Igor Borghi from Medtronic. I'm the lead of the gynecological health team of Western Europe. Welcome to this second webinar of our new series of gynecological health webinars. And I have with me my colleague, Nail Fahy. This is our medical affair for Western Europe. And we have two guests this evening, Dr. Ursula Catena and Professor Justin Clark. I want to introduce them and then we can start our webinar. And after all the talks of both of them, we will have a Q&A session. So please submit your question using the Q&A function. So first of all, I wanted to say thanks to Professor Justin Clark, who is a professor of gynecology at Birmingham University and consultant gynecologist at Women and Children's Hospital in Birmingham and president of BSG, the British Society of Gynecological Endoscopy. So welcome, Justin. And I wanted to say thanks also to Dr. Ursula Catena, which is a gynecologist at Policlinico Gemelli in Rome. She is the referent of the class digital hysteroscopic clinic, and she is the chair of SIG for hysteroscopy at ESG. Welcome, Ursula. So I think we can start immediately with the presentation. So Justin, I think the stage is yours.
Thank you very much, Igor. Thank you very much for inviting me, and thank you very much for those of you attending. So we'd like this webinar to be short and punchy and to allow some time for you to ask some questions as well. And I suppose it's really about the role of pathology removal in fertility treatment. And so Ursula is going to show us the technical aspects of this through a predominantly video presentation. I've got the slightly maybe more boring role of presenting some of the evidence or what we know or what we probably more likely what we don't know as to what we should be doing to enhance fertility as regard removing pathologies from within the uterine cavity. So these are my affiliations. So, you know, what is the evidence to support surgical management of intrauterine pathology? Well, it depends really upon the pathology you're talking about, but in the main, we're talking about acquired structural pathologies that are amenable to being removed from within the uterine cavity. So this is mainly uterine polyps, by far the most prevalent intrauterine acquired structural condition, but also submucosal fibroids and chronic retained products of conception, or some people refer to them placental remnants. I'm not going to talk about adhesions and septa, but I'm happy to take questions about those at the end if people do have questions around those acquired structural, well, adhesions are acquired structural lesions. Septa, of course, is a congenital adhesion, congenital structural pathology. So, okay, polyps. Polyps, what do we know about polyps? Well, they're so common. We're removing them all the time, particularly for abnormal bleeding, but as well as for fertility reasons. And it's definitely the most common pathology that's seen during diagnostic workup for fertility. And I get many sent to me to be removed for this indication. But despite how common they are, and you know, estimates of prevalence vary according to which populations you look at, we know surprisingly little about how they impact upon fertility. And I think that if you look at the data we have, it's mainly observational data. And a lot of this data is uncontrolled. And so it's quite difficult to make strong inferences from these data. But they do, despite their methodological weaknesses, do tend to suggest that spontaneous pregnancy rates may be enhanced if you see a polyp and remove it. Interesting, there's no randomized control trials to look at the effect of removing polyps on either spontaneous pregnancy or on IVF success rates, which might seem strange to you in 2022. I could only identify one RCT within a Cochrane review that evaluated the effect of hysteroscopic polypectomy. And this looked specifically at intrauterine insemination. And it did demonstrate a slight benefit. But if you look really, there's a reasonably sized study, a sort of 100 in each arm. And it does show a almost 4.5-fold increased likelihood of clinical pregnancy if you had a polyp diagnosed and you had it removed hysteroscopically, rather than you had it just biopsied and left otherwise in situ. So this is the only experimental, i.e. RCT data, that we actually have about removing polyps in terms of its impact on some form of fertility outcome, in this case, IUI. We have no data on enhancing or the effect on IVF outcomes, and no data on spontaneous pregnancy outcomes. Similarly with fibroids, we have little in the way, we have more data, but again, it's predominantly observational. So there's a Cochrane review that does include one RCT, which I'll show you in a second. And there's Elizabeth Pritt's observational systematic review. And they both basically identify studies that suggest that fertility outcomes may be enhanced, but because of the quality of the data, either the sample size or the study designs, it's very difficult to say with any sort of certainty whether we are doing a benefit or conferring a benefit. Certainly looking at the Pritt's review and looking at the controlled observational studies, and there were only two that really looked at the effect of removing submucosal fibroids against not removing them, they did show a 2-fold increase in the clinical pregnancy rate. Now, this didn't necessarily translate into an increased take-home baby rate, but it did seem to improve clinical pregnancy, which does to some degree suggest that these fibroids, as we think, by distorting the cavity or affecting the local environment or uterine contractility, are having some form of adverse effect on implantation. And then the one RCT, so just one RCT of removing fibroids, is tiny. It's from 2006. We got 52 patients in this study. And not surprisingly, when you get a very small trial, it's what's called very imprecise. The confidence limits are very wide because the numbers are too small. And inevitably, you end up with, as you can see here, non-significant results. So that's when the actual point estimate crosses this line here, the line of 1, where this side favors myomectomy, this side favors just leaving the fibroids in place and awaiting spontaneous pregnancy. But if you look at the point estimate overall, it's around 2.5. So the odds ratio of about 2.4. So the best guess we have is by removing a fibroid, it might enhance your the odds of becoming pregnant spontaneously by 2.5 times. However, it's not significant because it's compatible with actually a slight reduction, or it's incompatible with really quite a large, an odds ratio of 6. So a really quite big effect. And this is the problem with this study, because it's small overall. We can't say for certain that it's going to be beneficial. But there is some reasonably encouraging data that this study suggests that it is plausible that removing a fibroid, submucosal fibroid, may enhance fertility. Interesting though, this same study did look at miscarriage. Again, look at the numbers, they're tiny. So I don't think we can infer much from this. But again, these findings were non-significant. So we don't know really if removing fibroids submucosal fibroids has any impact upon miscarriage rates. And finally, the last acquired structural pathology that we commonly encounter outside of polyps and fibroids is retained products of conception. Now, There is also a lack of evidence on specific fertility benefits to date of removing RPOC. Will they just be absorbed and will be removed naturally later? Do they exert some sort of direct local effect on the endometrium, causing inflammation, infection, potentially adhesions, and impacting adversely on fertility? This is Pref on the bottom left of my screen, we've completed a pilot RCT looking at the role of randomizing between removing RPOC hysteroscopically with a tissue removal system, with a true clear system versus not. I'm looking primarily at live time to achieve the next pregnancy. So this is in women who want to become pregnant again. And that data will be available soon. We're following them up to 1 year. We're doing a very similar study, but it's a collaborative study sponsored by Medtronic, led by Angelina Hammerlink there in the middle, myself and Stephen Veyers and Mark Hansen Manuel. So a sort of international study from the UK, Belgium and the Netherlands, looking similarly at a much bigger study at whether if we remove these RPOC, are we going to improve fertility and time to next pregnancy? And we hope to sort of be able to publish these data within the next sort of 18 to 24 months. So we'll have a bit more idea about the impact of removing RPOC on spontaneous future conception. So, I mean, we do know some things though about persisting RPOC. We know that it's, if we use a mechanical tissue removal system, it's quick, it's effective, you get fewer incomplete evacuations compared to blind removal. And Angelina Hammerlink's group did look at cold loop resection, the conventional hysteroscopic method of removing RPOC, with the True Clear system. And what they did find is that they were both good techniques, but the True Clear system was much quicker and a faster alternative because it simultaneously cuts and aspirates tissue. And I suspect Ursula will be able to show you this clearly about how it's the system of choice, if you like, to remove, well, all structural pathologies, but particularly RPOC. So we do know that the mechanical tissue removal systems confer advantage over other hysteroscopic methods and over blind methods, but we still need more data to know what the actual impact is of removing these chronic RPOC on subsequent fertility. What magnitude of benefit, if any, does it confer, particularly as regard time to next pregnancy and pregnancy outcomes? So to conclude this short talk, we do need more data to understand who will benefit from removal of uterine pathology, specifically to look at enhancing reproductive outcomes. I'm not talking here about abnormal bleeding, for example. We're talking specifically about reproductive outcomes, so improving underlying fertility, improving outcomes from assisted conception, and reducing rates of miscarriage. But at the moment, I think most of us will remove these acquired structural pathologies, so polyps, myomas, and RPOC. And I don't think that's bad practice. I think that the observational data we have does suggest there is a benefit, but we should also be cognizant of the fact that these data are not robust. And so we should always keep an open mind as to how much of a benefit we are conferring on our patients. And so we do need more studies, and particularly randomized controlled trials to better guide us. But certainly at the moment, I think most of us are removing these pathologies because we believe they are likely to enhance women's fertility outcomes. Okay, so that's all I was going to say on this particular talk. I have a short talk at the end, but I will leave the floor now to Ursula.
Okay, so First of all, hello everybody. It is a pleasure for me to be here today with you. Thanks to Medtronic for the support. Thanks to Professor Clark for the fantastic presentation on all the evidence about pathologies, the removal of pathologies in fertile age. I think it is very important to discuss about the role of intrauterine pathologies in the infertile patient workup. Before to begin, I would like to remember you that you can ask questions on our Q&A chat. So, as discussed by Professor Clark, the treatment of intrauterine pathologies is fundamental to improve the subsequent pregnancy rate. For this reason, it is very important to take care of the uterus of our patient. Today, we will speak about the treatment of some of the most common intrauterine pathologies. So in this scenario, the concept of digital hysteroscopic clinic is fundamental. In fact, the integration between hysteroscopy and ultrasounds may improve the fertility outcomes of our patients. In fact, thanks to the concept of one-stop diagnosis, we can offer to our patients diagnosis, treatment, and postoperative control of the treatment of intrauterine pathologies in one single moment. Let's start from endometrial polyps. Surely, it is the most frequently observed pathological finding inside the uterus. The 82% of patients are asymptomatic, and endometrial polyps have been implicated in 35% of infertile patients. Surely, ultrasound is the gold standard to diagnose endometrial polyps, but to treat endometrial polyps, the most important thing is to choose the right instrument for the right patient. So in this case, ultrasound examination showed the presence of an hyperechoic lesion with an interruption of the midlines and feeding vessels from the posterior uterine wall. The hysteroscopic view shows a focal polypoid thickening on the left uterine wall in this area. And we just remove it with a grasping forceps, as you can see in the video. And the final histology showed an endometrial glandular polyp. In this other case, ultrasound examination showed the presence of this big hyperechoic lesion inside the uterus. The stereoscopic view showed two polyps originated from the anterior wall. We remove it very easily with a TrueClear Elite Mini system. This is very important because when you treat intrauterine pathologies with a tissue removal device, you respect the uterine cavity and you respect the surrounding endometrium, and you don't have thermal damage on the uterine cavity. And this is very important for the future fertility of our patient. And this was the final ultrasonographic view of the uterus. It is very important to use ultrasound after an hysteroscopic procedure because you have water inside the uterus. At the end, you perform also a sonohysterography in this setting. And this is very important because at the end, you perfectly check that all your pathologies inside the uterus, and also if there is a myometrial component, is removed from the uterus. So we can go just a little bit faster. And this is the final view inside the uterus. In this other case, we have a big polyp originating from inside the uterus enriching the external uterine orifice and the vagina. The polyp, you have also always to check where is originating the polyp. So this polyp originated from the posterior wall of the uterus. In this case, we decided to use a 5 millimeter bipolar mini resectoscope. And when you see a polyp inside the cavity, your question have always to be, this polyp will exit from the uterine cavity. In this case, the answer was yes, because it was a big polyp that originate from the uterus and exit from the cervix. So with very few movement of the loop, we completely remove the polyp from the uterine cavity. And this was the histology. So let's talk about uterine fibroids. Justin already gave you some clinical evidence about this. Everybody of us knew the FIGO classification system. So when we speak about hysteroscopic myomectomy, we are speaking about G0, G1, G2, and sometimes also the treatment of G3 myomas. The presurgical evaluation of uterine fibroids is fundamental. In our institution, we always evaluate patients with uterine fibroids with hysteroscopy and ultrasound. Also, in this case, the concept of digital hysteroscopic clinic is fundamental. In fact, in this setting, our patient underwent ultrasound, hysteroscopy, and then ultrasound that become hysterosonography for the presence of water inside the uterus. Only in this setting you can provide the real G of the fibroids and specifically describe the intracavitary and the intramural portion of the myoma. Only in case of big fibroids, like more than 3.5 centimeters, we use to give GnRH analogs to our patients. In all other cases, we give them progestins, so normally desogestrel or acetate norethistron, and this is effective in reducing the thickness of the endometrium, the severity of bleeding during the surgery, with the lower side effect respect to GnRH analog. We have different technique for hysteroscopic myomectomy. Surely the standard technique includes the use of the 26 French resectoscope that nowadays we use only in case of big myomas up of 3 centimeters. We have to remember that every time we decide to use a 26 French resectoscope, we have to dilatate the cervical canal. This is always a blind procedure during which we have always to consider possible complication. Other hysteroscopic options are the use of a 5 millimeter 15 French bipolar mini resectoscope or combined technique using 5 millimeter hysteroscope with 5 French forceps and then tissue removal devices. These options surely are operator dependent, but in selected cases allow you to treat these patients in an office setting and in some cases without anesthesia and surely without dilatation of the cervical canal. In all patients underwent hysteroscopic myomectomy, we perform a diagnostic control hysteroscopy after 30-40 days from the primary procedure to check the uterine cavity, to remove in an office setting some residual fibroids, or eventually to evaluate the possibility of a second time surgery. This is a case of a G0 fibroids of 3.5 centimeters treated with the standard technique. So with the 26 French resectoscope, always with bipolar energy. We used in this case a standard slicing technique. And slice by slice, we totally remove the fibroid from the uterine cavity. Remember in this case that you are using energy. it's a bipolar energy, but you have always to consider the fluid balance because of the possible of fluid overload syndrome, that in case of use of saline solution and bipolar energy is less respect to the monopolar surgery, but it's always a complication that can occur when you perform underwater surgery. And I want to show rapidly the end of the procedure. You see perfectly here the pseudocapsula, you reach the myometrium, and this was the final view. This was another case. This was a 2 centimeter G2 fibroids treated with a 5 millimeter bipolar mini resectoscope. The technique includes the use of a 90-degree angle loop to remove the intracavitary portion of the fibroids with the standard slicing technique, as you can see in the videos. Then we enter with the cold loop. When you are in this phase, you enter with the cold loop of the mini resectoscope and you detach the intramural component of the fibroid from the surrounding myometrium. This is very important because only in this way you can completely remove the fibroids in one single time. Afterward, you come back with the 90-degree bipolar loop and you will complete the myomectomy with the slicing technique. Here you can see very well the pseudocapsula and the fibroids with the myometrium in the and the pseudocapsula. And the final view, you coagulate with the bipolar energy, the fovea, and this is the end. This other case was a G1 myoma of 1.5 centimeter. We treat this patient in an office setting with the patient awake without anesthesia. We're starting with 5 French scissors. We sliced around the fibroids with 5 French scissors. And then with the scissors, we enter between the myoma and his pseudocapsula. So you go on. And you go here, as you can see, between the myoma and the pseudocapsula. When the myoma is quietly, completely detached from the uterine wall, with a tissue removal device. In this case, I used a TrueClear Elite Mini with a dense tissue blade to remove it very faster from the uterine cavity. This is very important when the patient is awake because you don't have to enter and exit from the cervical canal with the chips. You don't have to perform a lot of movements. So the patient is very, very calm during this procedure, and she finally was very happy to remove in an office setting without anesthesia the myoma from the uterine cavity. I want to show you the blade of the tissue removal device. This is the blade for dense tissue. It is very, very fast. if you have some little vessels on the fundus, you can use at the end of the procedure or during the first part of the procedure, you can use a bipolar electrode to coagulate that small vessels. And this was the fovea of the myoma after the procedures. This was another case of a young patient with this lesion inside the cavity. Also in this case, we decided to use a dense tissue blade to remove the pathology from the uterus. As you can see quite at the end of the video, this pathology had a very, very small pedicle, so it was quite completely detached. So the pedicle, it is at the fundal level and it was very, very small. And the final histology of this lesion was an adenomyoma. I want to show you the pedicle that was very strange because it was very, very small. It was quite completely detached from the uterus. And this was the final view. So let's talk about hysteroscopy and the retained product of conception, and I don't come back on the literature about this. So sure, hysteroscopy gives you a direct visualization of the uterine cavity and you remove the ARPOC in a precise and targeted fashion. In case of retained product of conception, we have always to evaluate the vascularization of the lesion and the possibility to manage the patient with uterine artery embolization before hysteroscopic uterine evacuation, like in these photos. This is a case of retained product of conception treated without previous uterine artery embolization. You can see the lesion that is located on the left uterine wall. And in this case, we decided I can see in all the cases we treated placenta remnant with tissue removal device. And here we used a TrueClear Elite Mini with soft tissue blade. And in few minutes, maybe a few seconds, you can completely remove the pathology from the uterus. This is, I think, the best way to remove placenta remnant because you are very targeted on the lesion and you totally respect the surrounding endometrium. You don't have thermal damage on the uterus, and this is very important for the fertile of these patients. And also with the tip of the tissue removal device, you can go very, very near to the tubal ostia. And this is very important because you completely remove all the tissue from the uterine cavity. And I want to give you this other case. This is a 35-year-old woman referred to us for a vascularized retained product of conception after a DNC. Ultrasound examination showed a type 3 ARPOC, so a highly vascularized mass with highly vascularized myometrium. So this patient underwent uterine artery embolization with spongostan, that is a resorbable substance. And look and remember the images of right and left uterine arteries of this patient. After embolization and before stereoscopic resection, ultrasound showed minimal vascularization, so a type 1 ARPOC according to Gutenberg classification. We entered the uterus. We saw the retained product of conception, that is here. We wait that the uterus get clean. We see a tubal ostium. I think that it was the right one. I don't see the other ostium, and I thought that the other ostium was covered by the placental remnant. So I started to remove with the soft tissue blade of the TrueClear Rct Mini. I started to remove the retained product of conception. You always have to close the window before to start to use the soft tissue blade, and then you can go. No bleeding in this case because the patient was also embolized. You see that really in few minutes you totally remove the pathology from the uterus. Also near to the tubal ostia. And at the end of the procedure, I saw that the tubal ostium was only one. So I thought that it was a left hemiuterus. Fortunately, I started to perform ultrasound to the patient. I did ultrasonographic reconstruction, and I saw that, I confirmed that maybe it was a left hemiuterus, and so I started to check for some other things. This was the right ovary, and I saw near and connected to the main hemiuterus a little non-cavitated horn, a right horn. That was 3.5 per 13 millimeters. So at the end, we had the diagnosis of this patient. So U4AC0V0 according SG classification. So a left hemiuterus with right non-cavitated rudimentary horn, and with a retained product of conception inside the left hemiuterus. And remember the two uterine arteries of this patient, the left one that was completely normal despite to the other one. Now let's see together for the conservative treatment of endometrial cancer. This is the standard 3-steps techniques that we use for focal early endometrial cancer. Actually, we use 15 French, so 5 millimeter mini resectoscope to treat these patients. In this technique, we have to remove the main lesion. we have to remove the endometrium laterally to the lesion, and then we have to remove the myometrium under the lesion. Then we perform multiple biopsies, random biopsies around the uterus. So we remove the main lesion. We go in the myometrium under the lesion. Then we treat this patient with the Mirena, and we perform biopsies every 3 months. And this is our standard technique. This was the Mirena placed after the procedure. Then I want to show you this other case in which we perform a visual DNC. We use this technique in case of diffuse endometrial hyperplasia or when we have diffuse polypoid endometrial thickening. For this procedure, we use always tissue removal device with a soft tissue blade. And this is very important because in this case, you can have a complete sampling of the uterine cavity, respecting the uterus of the patient and without using energy to prevent intrauterine adhesions. In this case, we removed the main polyp from the uterine cavity of the patient and we shaved the tissue. We call this technique visual DNC because it's like a curettage under vision of the uterus. So you perfectly see everything. You know that you are respecting the myometrium of the patient because you just remove the endometrium and you have a complete sample of the uterine cavity. Then you go on the left uterine wall and on the posterior uterine wall. Look in this polypoid area on the posterior wall. And this was the final view of the uterine cavity. And in the last month, we are starting to treat some cases of diffuse grading 2 non-infiltrating endometrial cancer with a new technique. So we decided to combine the bipolar mini resectoscopic technique with the tissue removal device. Why? Because with the bipolar system, we reach the myometrium where needed, but to remove all the pathological endometrium, in particular very near to the tubal ostium, we use the soft tissue blade of TrueClear Elite Mini. So in the region very near to the tubal ostia, like here, we decided in this case, I think here for the first time, to use tissue removal device, soft tissue blade. In this way, we think that we can an improvement in the response to treatment because we completely remove the cancer from the uterus of the patient, and we can prevent adhesions because we don't do complete ablation with the resectoscopic surgery in all the uterus of the patient, but we remove all the pathologic endometrium with the tissue removal device, and we use bipolar energy only where needed. So look very near to the tubal ostium, you remove completely the pathology from the uterus. And I think this is very, very useful, and I think this will be the future to treat these patients. Now, let's see together why it is important to respect the uterus. I want to show some cases in which we can see how what bed surgery can do inside the uterus. This was a case after a conservative treatment for early endometrial cancer in another center. Look at the synechia inside the uterus and this small area that was a localization of cancer near to the right tubal ostium. So in this case, we completely treated the synechia inside the uterus of the patient, because remember that this patient then have to have a baby inside this uterus. We remove the only localization of cancer there near to the right tubal ostium. And remember another thing, that without hysteroscopy, surely you never know that there, in very near to the tubal ostium, there was cancer inside the uterus of the patient. I go a little bit rapid. We removed that, and that was the only region where there was cancer inside the uterus, because all the other biopsies was negative, because this patient was under megestrol acetate treatment in the moment of surgery. And this was the final view. Another case of patient treated for a uterine septum in another center. Also in this case, we find a lot of adhesion inside the uterus. We saw the two tubal ostia. And also in this case, we remove all the adhesion from the uterus with the Collins loop of the mini resectoscope, and then with the 90-degree loop. This patient had 2 previous surgery in another center for uterine septum. Okay, it is stopped, I think. But it's okay. And the last one after laparotomic myomectomy. This patient had synechia, a polyp on the fundus of the uterus. And this big synechia, but it was like a myoma that was attached from the anterior to the posterior wall. So we started to restore her uterine cavity, removing this synechia myoma that was in the center of the uterus. Then we removed completely the myoma and then the polyp. Also in this case, it is very important to use miniaturized instrument, because with a big resectoscope, it is quite impossible to perform a surgery like this. And I want to show you the final view. And in this case, I have also the control after 40 days from the primary surgery. And I think that when you respect the uterus, the results can be amazing. This was the uterus of the patient after 40 days from the surgery. So in conclusion, it is important to learn from our mistakes. So dilatate the cervical canal only if needed. Do not exceed with the thermal damage of the uterus. Respect the endometrium. Pay attention to the uterine cavity during laparotomic myomectomies. Consider to use anti-adhesion barriers and come back into the uterus after 30-40 days if needed. Finally, I would like to invite you to the next ESG Congress that will be held in Porto from 2 to 5 October 2022. I hope that a lot of you can join us. Thank you for the attention, and remember to always respect the uterus. Thank you. Justin.
Okay, thank you very much, Ursula. Thank you for a lovely talk. Okay, so I think we've got sort of a short amount of time. I was very quickly, just finish off what I was going to say. So the final thing, 5 minutes maximum, and then hopefully some questions we can ask in the chat. So just a quick view on, Ursula showed you some fantastic videos of a whole range of technologies and how versatile the mechanical tissue removal systems are, and also the electrical resection. I'm just going to sort of present a little bit about the two approaches, electrical resection and mechanical histoscopic tissue removal. So you've seen the technologies. This is the TrueClear system. You have the smaller setups, which are 5 millimeters in diameter, which are suitable for vaginoscopy in the office setting. You have the slightly larger elite systems, which are more amenable to theatre setting, requiring some cervical dilatation. The bottom line is that there are some advantages to mechanical hysteroscopic tissue removal systems, specifically, again, talking about fertility, because you want to respect the uterus, as Ursula was saying, and what better way to respect the uterus than to avoid thermal damage or inadvertent thermal effect. And so careful, precise surgery is very important. And in the hands of surgeons like Ursula, electrical resection is absolutely fine. But undoubtedly, if you can use mechanical systems which are effective and efficient, then you can minimize the risk of thermal damage, and not only complications arising from that, but potential inflammation, inflammatory responses, and possibly adhesions. There's good data now really to show. We published a trial in the outpatient setting of 120 where patients were randomized between miniature electrode removal of polyps and TrueClear system. And we found quite clearly that if you use the mechanical hysteroscopic tissue removal, the TrueClear system, that it was quicker, it was less painful, it was more acceptable and far more successful. We pretty much treated every single polyp successfully, whereas whilst we resected the majority of the polyps with the miniature electrodes, we failed to actually retrieve the specimen in up to 1 in 5 cases due to actually patient tolerance. So this simultaneous mechanical cutting and aspiration is key to efficient surgery, but also particularly useful in the office-based setting. As regard fibroids, Mark Hansen Manuel's group, so Helene van Dongen, published showing that the learning curve for learning a mechanical tissue removal was much quicker for type 0 and type 1 fibroids than conventional resectoscopy. And Chelina Hammerlink's group showed that in a randomized study comparing removal of type 0, type 1 submucosal myomas, that unless the fibroids were particularly calcified, where electrical resection had an advantage, it seemed that by removing them mechanically, it was just as quick, just as feasible, and as using conventional tissue electrical resection, and so something that should really be considered to be used routinely. And so, as I say, with fertility, I think by avoiding unnecessarily, the key thing I think Ursula's pointed out is that you've got to remove the pathologies completely to enhance the fertility. And however you do that, that's the best way of doing it. But you must respect the uterus. And if you can do it without using unnecessary thermal energy and thermal artifacts, then I think that the fertility indication is probably better. So mechanical tissue removal is simple, safe, and effective. It's a short learning curve. Definite some advantages in terms of removing polyps, as I've shown, reduces the risk of thermal damage and then probably adhesions as a result. And because it simultaneously cuts and aspirates, it's very quick and efficient and very amenable then for using in an office setting. And I think that now we're all aware, and Ursula showed this nicely in her videos, that mechanical tissue removal is established in reproductive hysteroscopic surgery for removing all the lesions that we've discussed today. So thank you very much for your attention. And I hope now we can go to some Q&A in the final minutes.
Yes, thanks, Justin, and thanks, Ursula. That was really interesting. So we do have a couple of questions that we will be able to quickly get through. So the first one is, what is the diameter of true clear tissue removal system, and can it be used in the office setting without anesthesia sedation? So Ursula.
Yes, the TrueClear system, the Elite Mini that I normally use is a 6 millimeter total. I have a 6 millimeter total diameter. I used to use it in an office setting without anesthesia, and it is very easily to enter with a 6 millimeter instrument after you enter the uterus with a 5 millimeter hysteroscope. So I always start with the 5 millimeter hysteroscope, and if needed, I enter with the TrueClear Elite Mini 6 millimeters very easily without anesthesia.
Yeah, I tend to use the slightly smaller scope routinely. So I use the 5 millimeter, the office set, and it's 5.6 if you put the outer sheath on. But if you just use it without the outer sheath, which the majority of cases you can, it's 5 millimeter. It's got, even though it's a 0 degree scope, it's got a beveled edge, so it makes it easy to insert. And so for women who've had vaginal deliveries, you can pretty much always vaginoscopically insert a TrueClear system of 5 millimeters, and it will remove the most common pathologies, namely polyps and increasingly RPOC. But that's my usual practice, and without anesthesia, I should say.
Perfect. So then, is there a role for the tissue removal devices in placenta accreta, where the placenta is left behind for spontaneous expulsion?
Yes, you can consider the option, and in particular, I think that doing this kind of procedure under visions is always better than to do it in a blind way. So always consider the possibility to embolize patient before the procedure. So always use the color Doppler at ultrasound to evaluate the possible vascularization. And then I think it is always better to remove under vision the tissue.
I think it's a good question, and I think that increasingly people are managing accretas and leaving bits behind. I think increasingly, I think after any intervention, maybe a manual removal, a surgical evacuation after a full-term pregnancy, I think the risk, the endometrium is uniquely vulnerable to damage, and this group do end up with the Asherman syndrome, the adhesions. So I would very much say that these women should undergo an outpatient hysteroscopy 6 to 8 weeks later, and to have an inspection of the cavity and removal of any residual chronic bits of RPOC that may be left.
Then just on RPOC, so following miscarriage, after what time scale do you scan? That's a two-part question, but we'll go to that one first.
So
well,
I think...
Okay, Ursula, you go first.
Go, Justin.
Okay, Natalie, hi, Natalie. Yeah, well, actually, the honest answer is, if you look at the studies that were published on this chronic RPOC, they all seem to have removed them at around sort of 10 to 12 weeks post miscarriage, so that to allow them to become avascular and fibrinized and suitable for removal. But to answer your question directly, at what time would you scan? I mean, I think that most, certainly in the Netherlands and Belgium, most people, not so much in the UK, but most people routinely scan at around 6 weeks after the miscarriage to check for RPOC. And then at that point, as Ursula has put in her talk, it depends how vascular it is. If it's quite vascular, then I think it's probably worth, and they're not symptomatic, it's probably worth leaving it and rescanning 2 to 4 weeks later to see what it looks like. And if it's still there and not so vascular, then remove it. But at the moment, in the HIM study I showed, we were not removing them before 8 weeks because we were a bit worried about too much vascularity and bleeding. But Ursula, what do you do?
Yes, the same. I think that after 2 months, you have to evaluate patient, and every patient is different, because if patient bleed, you can evaluate the possibility to treat it. Otherwise, you can wait and you rescan after 4 or 5 weeks, and otherwise you proceed with hysteroscopic evacuation. And in case of vascularized retained product of conception, we use to embolize the patient, but our radiologists use spongostan that is reabsorbable in quite 3 days, more or less. So they do embolization with a spongostan. After 24 hours, we perform the stereoscopic uterine evacuation. And then after the next period, we ultrasonographic check the uterine arteries of the patient that normally are reperfused.
Perfect, brilliant. You answered the second part of the question as well, so that's good. So I'm just going to share my screen quickly because I know we're a little bit over time. Are you seeing the GYN Academy slide?
Yeah.
Yeah, perfect. So I just want to quickly announce that we will be launching this learning pathway in June, and it's specifically to do with the vaginoscopy technique. It's a pathway that will track you over around 6 months, and it'll have multiple different elements to it. So as you can see from the slide, it has vaginoscopy e-learning content, which I'll go into in a bit more detail in a second. Then it'll have digital clinical immersion following on from that. And then finally, a digital proctorship, where you, the delegate, will go away and record your own procedure and come back and review it with our faculty. So the digital e-learning content that will be housed on WebSurge, which is the EARCAD website, and that will, the course itself will bring you through multiple modules, and it'll show you exactly how to do the vaginoscopic technique and what considerations you should have when performing and before performing it. So things like the setup of your office, what equipment you need, what pathologies you can treat in the office, and patient selection, when to abort the procedure, those kind of things. Then following on from that, you will do a digital clinical immersion, where our expert faculty will bring you through 5 or 6 procedures, again, showing you the range of pathologies that can be treated with the vaginoscopic technique in the office. And then after that, again, as I mentioned, you'll be doing a proctorship, a digital proctorship, where you go and practice the technique yourself, record the procedures, and then you come back online with our expert faculty and review it. And that's a process that can be repeated multiple times until the faculty feel that that you can complete the pathway and be certified. So if you're interested in that pathway, then after you leave this webinar, you will be brought directly to this page where you can fill out the form. It'll take about 30 seconds to fill out the form, just your institution, your email address, and what's your current level of experience. And then after that, I will follow up with you in a couple of weeks to get you registered on the pathway. And in June, we'll launch the pathway, and you can start with the e-learning content. Perfect. So that is all from me. Again, I'd like to thank Professor Clark and Dr. Ursula, Katena for joining us today and putting together those presentations. I think it really was an interesting session. So thanks again for that. I'd like to thank WebSurge for hosting the webinar. And also I'd like to thank the delegates for joining, or for the attendees to joining, for taking the time out of your evening to join. So thanks everyone. Thanks for joining.
Thank you very much. Goodbye.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye.